One always has exaggerated ideas about what one doesn't know. Exaggerated placental-site or EPS is a rare gestational trophoblastic disease with limited knowledge on its clinical course, diagnostics, and management. Good morning. This is a case of 25-year-old Gravida 6 5005 who came in due to vaginal bleeding. Past, family, personal, menstrual, gynecologic, and sexual history were non-contributory. Patient had 5 pregnancies, all alive, carried to term, delivered via NSD without any fetal-maternal complication. Her last delivery was 7 months from her present pregnancy. Patient had her missed menses for 13 weeks until 6 days prior to admission. Patient had vaginal bleeding for 5 days with hypogastric pain and passage of meaty material. 3 days prior to admission, still with vaginal bleeding and positive pregnancy test, prompted consult in a lying-in and managed as a case of abortion. Transvaginal ultrasound was requested, revealed uterus is slightly enlarged with snowstorm appearance, and considered highly deformed mole. On the day of admission, still with vaginal bleeding accompanied with generalized weakness, prompted consult in our institution. At the ER, patient was conscious, coherent, pale-looking, and wheelchair-borne with the following vital signs. Pelvic exam shows cervix pink, smooth, no lesions, open with vaginal bleeding. Uterus enlarged to 14-week size. No adnexal mass nor tenderness. Baseline beta HCG was 10,000 milli-IU per ml with very severe anemia on CBC. The patient was admitted for molar pregnancy. Blood transfusion was done prior to operation. She has completed her desired family size and consented for exploratory laparotomy, total abdominal hysterectomy with bilateral self-injectomy under general anesthesia. On laparotomy, uterus measured 8.5 by 8 by 5 centimeter. On cut section, polypoid tissue admixed with blood and focal areas of hemorrhages were seen in the fundal area. Post-operative course was unremarkable and was discharged with decreased serum beta HCG. Specimen sent for histopathology. Low scanning view showed a diffuse and infiltrative growth of a typical monomorphic intermediate trophoblast arranged in sheets and cords, infiltrating the myometrial smooth muscle fibers with areas of hemorrhages and necrosis. Uterine blood vessel wall was replaced with extensive fibrinoid deposition and presence of chorionic villi. Histopath report showed the following. Immunohistochemical staining of Ki67 was done to support the diagnosis. In our patient, this staining did not show proliferation, which is consistent with a non-neoplastic exaggerated placental site. We concluded that this is a rare case of exaggerated placental site. Trophoblastic stem cells develop along 2 lines of differentiation, villus and extravillus. Molar pregnancies and choriocarcinomas are derived from villus trophoblast, which are composed mostly of cytotrophoblast and syncytiotrophoblasts. Extravillus trophoblasts are composed of implantation site and those from chorionic type intermediate trophoblast. Exaggerated placental site or EPS and placental site trophoblastic tumor or PSTT are lesions from implantation site, while placental site nodule or PSN and epithelial trophoblastic tumor or ETT are lesions from chorionic type. EPS and PSN are non-neoplastic lesions, whereas PSTTs and ETTs are neoplasms with potential for local invasion and metastasis. Our case is under implantation site. During early gestation, intermediate implantation site trophoblast or ISIT infiltrate the decidua and invade the myometrium and spiral arteries. This is important in establishing the maternal fetal circulation. Physiologically, only the upper third of the myometrium is invaded by these cells and regress progressively over a period of time. In EPS, ISIT infiltrate the myometrium exaggeratedly. This may be due to rapid cell cycle progression of intermediate trophoblast or the suppression of apoptosis of IT in the deep implantation site. Only 25 published international case reports, and this is the first reported case locally. An important differential of EPS is PSTT. These are their clinical and pathologic features. All highlighted ones are present in our patient. In EPS, antecedent pregnancy can be from any type of pregnancy, from present to years after pregnancy. Beta HCG level in EPS is same with normal pregnancy. Gross specimen will show presence or absence of tumor. There is no mitosis in EPS. Chorionic villi is present in EPS and absent in PSTT. Here's a stepwise approach using immunohistochemical staining differentiating trophoblastic lesion. The first tier discriminate a trophoblastic versus a non-trophoblastic lesion. Second tier differentiate implantation site from chorionic type. And the third tier distinguishes a benign versus a trophoblastic neoplasm by using Ki67 and cyclin E. Ki67 will stain less than 1% for EPS and more than 10% in PSTT. We adopted this algorithm but modified the approach. Diagnosis of trophoblastic lesions are straightforward based on clinical and morphologic features. In our patient, these are consistent with an intermediate implantation site lesion. A beta HCG of 10,000 IU per ml seen in our patient will rule out ETT because it presents a low beta HCG of less than 2,500 IU per ml. PSN was ruled out because morphological architecture in our case did not present a well-circumscribed nodular aggregates of chorionic type IT. Presence of chorionic villi is greatly associated with EPS. To support the diagnosis, Ki-67 immune staining was done, which showed no staining, confirming the diagnosis of exaggerated placental site. Management for PSTT is hysterectomy with adjuvant chemotherapy for those presenting greater than 4 years from the antecedent pregnancy, while in EPS will depend on the clinical presentation of the patient and the desire to maintain fertility. Based on 25 case reports, majority underwent hysterectomy and only one underwent hysteroscopic resection. Our patient underwent hysterectomy. There are limited information about this type of GTD, and this case report will give us additional understanding. EPS is a benign lesion, while PSTT has tendency to follow a malignant course. Immunohistochemical staining is warranted to support the diagnosis. If it is diagnosed accurately, it will prevent frustrations on the part of the clinician and lessen the financial and emotional burden to the patient. Getting the right diagnosis is a key aspect of healthcare. Improving the diagnostic process is possible if we have enough knowledge of the case at hand because it is our moral, professional, and public health obligation as clinicians. To avoid overmanagement is to avoid overdiagnosis. We tend to have exaggerated knowledge of the things we don't know about. The knowledge we gain from this case will guide us to be more cautious in our treatment, thereby avoiding overdiagnosis resulting to overmanagement. Thank you and good day.